you, Anand. So I just want to ask of the audience who's familiar with the subthreshold macular laser? Raise their hands, or is this just the first time? Okay. So this is actually very basic. These are my disclosures. Of note, I serve as a consultant for Lumibird, who is one of the manufacturers of the laser companies. So we're going to be talking and making the differentiation between conventional laser photocoagulation, and it causes significant chororetinal damage even when properly performed. And we can decrease the damage by changing the laser parameters and the clinical endpoints. So this is the reason why the micropulse or subthreshold laser was developed, to try to eliminate this iatrogenic damage from conventional macular photocoagulation. So you can see here, this patient was treated with actual parameters from the ETDRS. But years later, many years later, the patient has no macular edema, but technically he's kind of blind, because you can see that with time, the scars sort of expand. So what's in the name? So when we talk about conventional macular photocoagulation, we're referring to continuous wave photocoagulation. That means that when you press down the pedal, and remember there's a time and also the power. Once you press it down, then you're going to deliver the power for the entire time. The subthreshold means that there's no visible reaction while performing the laser. Micropulse, the name micropulse is a patented name that actually is by Iridex, and before then it was used very openly by all the other companies, but then Iridex started enforcing their patents, so other companies had to come up with other names. So for instance here, the Quantel people use it subliminal, and the idea is to deliver energy in pulses, so no damage to Bruch's membrane is going to happen. Both of these are subthreshold modalities of laser treatment, but not all subthreshold modalities are the same as micropulse or subliminal. So here's an illustration, a cartoon that of what conventional photocoagulation is. So you see here that when you press the foot pedal, the power goes up to whatever you determine it, and it stays on for the entire pulse, the duration of the pulse. So one of the things that you can do, and you have to remember to lower the damage, is you can actually reduce the spot size and adjust power to reduce the irradiation. Just remember that the power is a function of you have to remember that in a circle, the power delivered is more when the spot size is smaller. So you also have to reduce the power, but you have to do it by 4, because remember, it's a circle, so it's pi r square, the relationship. So the retinal temperature rise is proportional to the irradiation. Remember that the target is the RPE, and what we want to do is try to stay within the RPE. If we stay with the time too long, then we're going to have that beam of energy that's going to be expanding in the horizontal direction and also in the vertical direction. So that's why that we want to reduce the times. So I've shown you a couple ways that you can reduce the iatrogenic things when you're doing conventional laser photocoagulation. One of them is to reduce the retinal irradiation, and the other is reduce the pulse duration. So let me introduce to you now the term of the micropulse or subliminal, where the idea is that here you have the entire duration of the pulse, but what we've done is that we only select a portion of that time where the laser is firing, and the rest of the time the laser is off. So this will allow you to actually concentrate on the RPE, and the heat will not rise up, and then you can avoid having that lateral expansion and the vertical expansion of the heat wave. Remember that for this is a macular treatment, so we're not talking about doing PRP with micropulse or anything like that. So the idea is just to treat the macula because we want to avoid iatrogenic damage to the macular area. The ideal macular laser, in my opinion, is that it should be micropulse or subliminal. The wavelength is important. We prefer the yellow, and also have the multi-spot technology or have the patterns. And also it has to have the ability to have the low duty cycle. So again, subthreshold, no visible reaction while performing the laser. And subliminal is that the energy delivers in pulses, so there is no damage to Brooks membrane. So again, here you can see that we choose the power, and the power goes off, and the rest of the cycle, the laser is not firing, so that allows the tissue to cool down and do not have the iatrogenic problem. Duty cycle, again, is just the percentage of time that the laser is firing in relationship to the time where you've chosen the pulse. So a 5% duty cycle means that 5% of the time the laser is firing, but 95% of the time the laser is not firing, so you have time for it to cool off. So does it matter the wavelength? And you have to remember, you know, there are several wavelengths that we can use here, as noted here. And the 577 is particularly good for macular work, because remember that one of the main tissues that absorbs the heat is the oxyhemoglobin and the melanin. The melanin is concentrated. Here you can see the absorption curves, and the yellow laser has a good absorption curve. This is in the RPE. But if you want to treat the vascular structures, you can see here's a peak here, and you can also here get the most. And the most important thing here, you can see the extension curve for xanthophyll. And the xanthophyll, remember, is a pigment that is in the macular area. You do not want that to be absorbing. For instance, here the green, you can create iatrogenic damage for that. You can see the yellow here is far to the right, and there's really no absorption there. So 577 also provides greater transmittance through some corneal and lenticular opacities. There's no absorption by the macular pigments, rendering much safer to use in the macular area. And in patients with light or irregular fundus pigmentations, provides a more uniform effect. So yes, the wavelength matters, and I show you that the yellow is perhaps better. In addition, it allows to titrate power directly under the subliminal mode that allows to reach a visible endpoint. So there are two schools of thought. One is that you can use fixed powers to treat in the micropulse mode, whereas others like myself and the rest of the panel here believe that it's important to titrate because not everybody's pigmentation is the same. So a Caucasian patient probably is not the same as an African patient. Where there's more pigment, you probably require less power because there's more absorption. And in the past, when we had the 810 nanometer laser, for instance, it was not possible to really titrate power directly in the micropulse mode. You had to do it under conventional photocoagulation mode, and sometimes accidents occur because you chose the power, but you forgot to switch back to the micropulse mode, and you're treating in the macula, and you go, oops, and that can be a problem. The multi-spot is also important. So multi-spot refers to the patterns. So you can get a step on the pedal, and then you get a pattern of burns. And the importance of this is because since the burns are invisible, we really need to use this to treat the more area more efficiently, because the most common cause of treatment failure is under-treatment. And typically in all our cases, what we recommend is to use the high-density treatment. High density means that the burns are contiguous one to the other, and we can just treat them with the pattern. You can imagine if you only had like monospots and those burns are invisible, how can you really treat the whole area and make sure that you're treating uniformly when they are invisible, right? So that's why the pattern is important. And this is an example. The Brazilians did a study here where they did high density, normal density, and conventional modified ETDRS. And here you can see that for the most part, the best results were in people where there was a high density. Let me skip this. And finally, talking about the duty cycle in the past, because of the technology, the first one was 15% duty cycle, then they came down to 10%, and now down to 5%. And the reason is that in animal studies, this is a poster that Victor Chong presented in ARVO many years ago. You can see that the lowest iatrogenic damage that occurred in the rabbits was with the 5% duty cycle when compared to other duty cycles. So it's just safer. Okay. All right. So the idea is whenever we have the patient here, we titrate, and the way of titrating this is that you go outside the arcades and then you start shooting the laser under the micropulse mode until you get a barely visible burn, and then you cut down the power to 50%. This is kind of our recommendation. Some people say a third, 50%. Nobody really knows exactly what, but that's the idea, to keep it in the safe side. And also, when we treat DME, we are not really aiming to the areas of leakage per se, like we use the fluorescein angiogram as a guide. We mostly just use the OCT and try to treat the thickened areas. So in summary, the key characteristics of an ideal laser for macular work should be that it has the capacity to work under the subliminal or micropulse mode, that it has the capacity of the patterns with the multi-spots, the yellow wavelength, and the ability to have a low duty cycle. Thank you very much for your attention.